look at the interventional heart failure space, it's blossoming. Whether it's shunt, whether it's coronary sinus dimension reduction.
Hey guys, Andrei Pop here. Welcome again to our channel. We're lucky today to have Firas Zahr join us. He is a expert structuralist and he is the PI for the Outflow trial. We are part of the trial at Alexian Brothers. We've randomized recently our first patient. I went to the animal lab. It's a very exciting technology and wanted to talk with Firas about this. So welcome, Firas.
Oh, thank you, Andrei. Thank you for having me. And although I'm casual, but I promise you, I occasionally work and put scrubs and hats as well. So
Yeah, we're just talking about how we're both on administrative time, but I got
that's
sucked in the
right.
lab like it always happens. So, Firas, outflow is basically a shunt that we create between the left atrium and the coronary sinus. Prior attempts at shunting inside the heart have not really worked that great for heart failure. I have one patient who has a shunt and who's super happy with the shunt, but the trial that he was part of was a negative trial. Why is this going to be any different?
Yeah, I mean, this is I think you said it very well, Andrea. As there are a few elements. One is, shunt is variable. The size of the shunt is variable, the location of the shunt is variable. But although we might assume that it's just shunting blood from one chamber of the heart to another, but I think there is more into it. And the location of the shunt might, play a role, less disruption to flow, how big is the shunt, and how patent it will remain after a period of time. I think all of those are variabilities in the shunt. Number two is, as you stated, it's for heart failure. And heart failure is a broad terminology, and we haven't figured out yet which heart failure patients shunt work for the best. Is it those with preserved ejection fraction, those with decreased ejection fractions, those who have certain characteristics? And I think that this is probably why we see the data all over the place in terms of benefit from the shunt. Also, what outcome we look at? Is it do we look at decrease in wedge pressure? Is it quality of life? Is it exercise tolerance? So I think there's a lot of variables that we look at when it comes to shunt, and the broader the terminology, the more lost we get. And I think that we haven't found the sweet spot yet in terms of patient characteristics, shunt characteristics, pulmonary hypertension, that we will find the patients who will benefit the most. I think all of us have patients who have done remarkably well with shunts, and we've seen some who you put the shunt in and they cannot tell the difference.
Yeah, it's certainly a fascinating subject, and you mentioned something that really hit home for me, and this is something that I learned actually when I went to Irvine to work in the animal lab, which is that we're seeing a lot of patients for the trial referred actually not out of the heart failure clinic, but out of the structural clinic. And having just sent an email to my partner saying, hey, send me your patients who did not get better after we fixed their aortic valve, their mitral valve, their tricuspid valve. We put stents in them. We ablated their AFib. It turns out that there's a lot of those patients.
Yep, yep. And I think that this is the field that we are in. And, many patients benefit from medical therapy, but medical therapy take us, so far. And I think all of us have seen patients post TAVR that, they felt better, but they're still symptomatic. And we wonder why. Your comment about, a MitraClip patients is so true. And, I have patients who you do an LAA procedure on them, and ironically enough, you see them and they're feeling better. And like, well, you're not supposed to feel better. We didn't do anything that make you feel better. And but maybe it is the shunt in some of those patients. So I don't think we understand it well, and I think your point is very well taken that despite stenting sometimes and medical therapy and AFib ablation, we still have some patients that are symptomatic.
Yeah, no, I think you're right. We occasionally see patients where we make a transeptal puncture for some other reason and they feel a lot better. And as you said, if you're doing left atrial appendage occlusion, they shouldn't feel better.
Right.
Um, how about risk of stroke? Because we're always, we're actively closing holes to prevent stroke, and now we're creating holes.
Yeah, I mean, I think that this is one of the advantages of a shunt that is in between the left atrium and the coronary sinus. I mean, the risk of stroke is a lot less because it's unlikely that you're going to reverse the blood flow in the entirety of the coronary sinus, as opposed to an intra-atrial shunt where periodically you might have a reversal of the shunt from left to right to left. With that being said, though, the safety profile of the shunting in terms of stroke, even for the intra-atrial shunts, have been low. So, but I do believe that preserving the intra-atrial septum might have value in case patients need procedure via the transseptal axis in the future. So, preserving that might have added value.
Yeah, no, I think right now we're realizing that the interhydroceptal is very important, and
Yep.
we used it for so many procedures, and there's still a big debate whether it's easier to go through a Amplatz or Gore cardioform. Each company has its own theories, but we've certainly done both, and we've gone around, and it's not necessarily an easy procedure once you have to do that.
Right. Right.
Um, the other thing that I learned at the investigator meeting about this PCWL, the basically the workload corrected pulmonary capillary wedge pressure, which was something that was very interesting to me because basically I think most labs outside of academia don't do stress testing in the lab,
Yes.
and I think that we may be seeing a comeback of that. I understand somebody told me less than 10% of the labs around the country have the capability to do a stress test in the lab.
Yeah, I mean, I think your point is spot on. I mean, the resting hemodynamics does not necessarily accurately predict exercise hemodynamics. And I entered this field when we started doing exercise stress testing in the cath lab, and saying, "Oh gosh, what are we doing? It's going to eat up half of my day. You're not going to be able to do any other procedures." But then you realize how eye-opening it is. You'll see some patients that the wedge shoot up, the right atrial pressures remain flat. And you'll tell yourself, those are maybe the one that will benefit from shunting. You see some that, the right atrial pressure goes up and the left atrial pressure goes up, and you say, okay, it seems like there is a profound myopathic process that impacting both left ventricle and right ventricle. And some of them you see the pulmonary pressures go up, and open your eyes about whether or not you should put them on some pH therapy. Some of them you see the V wave shot up, and they have hidden MR that you did not direct on the transthoracic. So it really opened my eyes when you start doing right heart cath exercise about what you learn when you put the patient on a bike. In fact, you're gonna laugh at this, but exercising that just exacerbate the findings. But just having the patient on the table and have them raise their feet on the bike, you will see those hemodynamics shift, right away. Obviously, they exaggerate with exercise, but the earlier sign happened just by raising their feet up. And I tell you how the physiology is for those patients when they walk around and they go up the stairs, and tell you why they're symptomatic. It's just by raising the feet, the hemodynamics become, so obvious. And then the other thing that the right heart cath exercise open your eyes to is what you have described is what is an adequate workload, for every patient. So the fact that your wedge got to 40 at 20 watts, and that is not normal. And you're going to be a lot more symptomatic than if your wedge get to 40, but at 80 watts. So, the how prone the patient is to a specific workload and how easy it is to produce the symptoms is also something that we've learned from right heart cath exercise. So it's still not my favorite procedure to do, I'll be honest, but I find it a lot more valuable in help taking care of patients.
Yeah, see, I transcended this. I have somebody else do the right heart cath with exercise. I just do the procedures.
Yeah, but you still look at the data, I bet.
Yes, it's
Yeah,
true.
yeah,
And I have to tell you, I think one of the things that I loved the most about the investigator meeting was when you had a heart failure doctor on the podium talking about how to optimize the tracings during the exercise cath and how to use 8 French catheters. And I was like, this is great. Up
yep.
until now, nobody cared about the tracings. And now all of a sudden people are interested. And we're moving back from, everything we do is 5 French these days, and we're moving back into 8 French.
Yeah, part of the reason for that, Andre, I think that we have a larger gamut of therapy right now. I mean, before you say, okay, I'm going to do all of this, and what I'm going to do at the end of it, maybe a little bit more Lasix. Oh, well, let me just give more Lasix and forget about all of this. But now, I mean, look at the interventional heart failure space. It's blossoming. Whether it's shunt, whether it's coronary sinus dimension reduction, whether it's subvalvular annular reduction. I mean, that space is blossoming, not just with device therapy, but also with medical therapy. So, I feel a little bit more bullish about doing those exercise physiology and spending more time trying to understand it more. I mean, at the end of the day, what we want is not to do procedure, but to help patients. And if we can understand the physiology more, that is a positive thing. And I think what we have in terms of tools right now is very different than what we did a few years ago.
And I think that there's many companies that are interested in this space and are exploring this space. And it's kind of a testament to the fact that, as you said, 10 years ago, we had zero therapies for diastolic dysfunction. And now we're starting to see a full array of therapies that have benefit in diastolic dysfunctions. And there's more to come.
Yeah, I mean, I hope so. This is a difficult patient population to treat. And, I'm not saying that, shunt, cure that. Don't, but I think it's a step in that direction. Uh, you know, this is why, the outflow 2 is unique, and many other shunt trials as well. They're randomizing to sham. With how difficult it is to randomize to sham, I think this is the only way that we'll find out. I just hope that we understand better what patient population will benefit from shunt. Because as you stated at the beginning of this dialogue, we all have patients who tells you, Doc, I felt great after the shunt. On the other hand, we have some who say, maybe not so much.
Yeah, and I think, this is a discussion that I always have with my patients, and I tell them, these studies are expensive to do, and companies don't want to waste money on the wrong patient population. And, they're gonna go for the patient population that is likely to have the maximum
Yep,
benefit so that they can be most economical. And then once the device gets in the wild, things happen. People apply them differently, then we get follow-up data and whatever. But whenever you start with a trial, you're going to start with the patient population that's most likely to benefit and
yep.
give you a positive trial.
Yep. No, absolutely. And as you stated, I mean, the endpoint for those trials is also of a challenge. I mean, whether you use the wedge, when you use the wedge to workload, whether you use the quality of life, whether you use the 6-minute walk, whether you use, I mean, there's just what endpoint, heart failure, hospitalization. I mean, there is the endpoints that you trace is extremely important as well.
Yeah, no, I totally agree, and it's certainly a difficult patient population to deal with. And the other thing that I found super interesting at the investigator meeting was that there were actually heart failure doctors who wanted to see diastolic dysfunction patients because when we started our heart failure service, they all they wanted to see were people who potentially could get LVADs and had bad LV dysfunction. Now, with new therapies, they're all of a sudden a lot more interested in seeing some of the patients that make me pull my hair out.
Yeah, I think the nobody wants to see patients who tell them there's nothing to do, right? I
Right.
mean, this is probably why many of us, including the heart failure docs, were not so enthused about, seeing those patients because, at the end of the day, you're going to tell them, uh, I have nothing much but diuretics. I think the current era, though, whether in medical therapy or more recently with device therapy, there's a lot to offer to those patients, and so that rewarding patient-doctor relationship, what you're doing is actually helping patients, and you're getting this positive feedback when patients tell you I'm feeling better. I think this is probably part of why this has changed because now there is a lot that you can offer those patients where before they're very little.
Yeah, I agree, and I think it's nice to have at least some options because not everybody will lose all the weight as much as we'd like them to. Not everybody will go on CPAP as much as we'd like them to, and uh, we just telling patients to do things themselves is not always enough. Um, so wanted to ask you, one of the exclusion criteria for the trials is the presence of a coronary sinus lead. Um, is that mainly related to the fact that it's a pain in the neck to operate around a coronary sinus lead? Is it because you're afraid of dislodging it? Because I have the feeling that if this is a positive trial, the moment this gets out in the wild, people are going to start doing it regardless of the lead.
Yeah, I mean that is a very good point. I mean, I think there are multiple reasons why you exclude certain patient population, especially with those pacemaker. One is obviously safety, and in a trial where you're questioning or testing the efficacy of a therapy, you don't want to introduce any safety concern in a sham controlled trial. We have treated, though, in Outflow 1, we have treated patients who have pacemaker lead in their coronary sinus, and they have done well. So there was no issues in getting the device in the coronary sinus and take it out. But nonetheless, I mean, you have a proven therapy, which is by V-pacing, that you are risking by doing this procedure. So unless you are sure that there is benefit, it is hard to expose the patient to additional risk of dislodging their pacemaker, despite the fact that the EFS, outflow EFS, did not demonstrate that signal. The other aspect of it, in some trials, I mean, whether it's a pacemaker or the surrogate for pacemaker, have been shown to be associated with lack of response to shunt. So they might have played a role as well.
Yeah, no, it's a absolutely fascinating subject, and it's interesting. This whole thing of with the field of interventional heart failure is absolutely exploding, and it's going to be very interesting to see a new generation of heart failure specialists join us in the cath lab.
Well, and Andre, I mean, also it's going to be a new generation of interventional cardiologists. I mean, let's just accept it. Neither one of us is that young, and the field of interventional heart failure is really attracting a lot of young heart failure and interventionalists at the same time. It's a little bit different. I mean, we grew up in the era of Cypher and Taxus, and we
Right.
were debating which stent is better. And now we're talking about putting shunts in the coronary sinus and rings underneath the mitral valve and devices in the coronary sinus. So it is exciting. It is exciting time.
Yeah, it's certainly exciting, and there's so many new technologies coming down the pike, and it's it's going to be interesting to see how much how much industry is willing to keep investing. Because I think with certain things, if prices start coming down, then there's going to be a lot less interest to innovate and to push new technology. So
Yeah.
it's i- there's more than just medicine. There's economics that come into play as well.
Yeah, and listen, I mean, there is no the shunt space has been hit by multiple negative trials, as you alluded to. I mean, it is not a secret, and that will have an impact on what gets done. I mean, luckily, there are still significant belief, and I think part of it is driven by some subgroup of patients who significantly improve after shunting, that there is still significant investment in the space. I mean, we talk about Alpha 2, but there are also many trials that are either in their second randomized trials or embarking on starting a randomized trial or even first in human that are getting into EFS trial that are currently undergoing in the US and outside. So I think the story is not over yet. And I am cautiously optimistic that they will be a happy space, that we can see an improvement that justify the cost that is associated with this technology.
Yeah, and I have to say again, granted, my experience was in an animal model, but you know, it's a fast procedure. I mean, it's not a highly complicated procedure. It's definitely not a tri-clip. It's much more along the lines of a TAVR these days.
Yeah, and I think your point is well taken. That those procedure has to be straightforward, has to be safe. There has to be with minimal risk of complications. I mean, the safety profile has to be proven. And the earlier data of almost all of the shunts that are currently in pivotal trial have demonstrated, at least earlier on, procedural safety. And also, like, kudos to the team, that if you look at across the country, it is some of the best interventional team that have been implanting those shunts so far. And I think that this is probably what we owe to our patients at this level, is our best expertise in terms of heart failure, in terms of interventional, in terms of our knowledge of disease. Early on, we involved even electrophysiologists to help us with coronary sinus. I think a lot of us right now are a lot more comfortable with doing procedures in the coronary sinus for various reasons.
Yeah, and we certainly learned a lot from the electrophysiologists. Most of us learned to do transeptal puncture from them because,
Right.
as you said, when we were doing Taxus versus Cypher, we had very limited exposure to transeptal puncture, and now has become second
Yep.
nature. So,
Yep. Yep.
yeah, no, this
Yeah.
is super exciting. I think people really need to pay attention to this space because it's coming. And if we have a positive trial, then there's going to be a bigger trial afterwards, right? Um, so
That's the hope. I mean, that is the hope. And then once you have a device that gets FDA approval, then you think about randomizing device A versus device B. And but I think the most exciting thing right now, in my opinion, is trying to find out which patient population is going to benefit the most from shunt.
yeah, and I think that there's so many variations there, right? I mean, you have the HFpEF, the head HFrEF, and subsets of those, and then you get the amyloids coming in, and there's gonna be decades of research in this space, I think, and we're just scratching the surface.
Right, and you're absolutely right. I mean, we try to lump all of quote unquote half PEF under one umbrella, but we know it is not true. Half PEF that happened because of AS is different than half PEF that happened because of amyloid, is different than half PEF that happened because of obesity, heart disease is different than HFpEF that happen because of hypertensive heart disease. I mean, we try to lump them all under HFpEF, but they're not.
Yeah, no, it's they certainly are different, and again, in a trial setting, we have to get an initial answer, and then once this gets out, we're gonna keep learning about the therapy for many years.
Absolutely.
Um, well, this is super exciting. I look forward to more cases. I'm trying uh, to beat the people who have enrolled a lot of patients. So I'm cracking the whip here. We'll see how that goes. Um, but again, thank you for this, and looking forward to working on many more projects together.
Likewise, Andre, I look forward to working with you on this and many other projects, and I have no doubt that you will do amazing work for the trial, for your patients, and for science. And this is a wonderful partnership. I thank you, and I thank Murmur MD for having me today.
Thank you.